Hello students, and this is the presentation about shock, and the mortality rate for the shock is very high. So, and um, a famous American surgeon of 19th century, whose name was John Warren, John Collins Warren, he said that a shock is a momentary pause in the act of death. And when he's referring it to pause, that means that's the little window where the healthcare team has an opportunity to save this patient. Shock is either caused by a pump problem or the heart problem or the heart pump problem or a problem with the blood circulating through the uh, big vessels in our body or lungs or heart. And what the why it's so important, because it is a condition, it is a state where there is reduction in systemic tissue perfusion. When there is reduction in systemic tissue perfusion, it results in decreased delivery of oxygen and reduced removal of waste products. When there is reduced removal of waste products, it leads to tissue injury or damage. So shock is a very important topic in any nursing or medical program. Imagine a patient with shock, and this is just a small picture which I pulled out from the web, and it will have, the generic signs and symptoms of shock are, low BP, oliguria, cold clammy skin, rapid shallow breathing. So, I mean, you have a mental picture of the shocky client. He will be having cold skin, weak thready pulse, low BP, tachycardia. But how would you want to know, how would you know that what kind of shock in progress? Because the treatment for the shock is to quickly correct the underlying problem while trying to maintain the circulation so that all body's vital organs are, surviving, and you are preserving those body tissues. And you can't do this unless you understand which type of shock your client is experiencing or your patient is experiencing. And different kind of shocks can happen due to a number of different causes, but all pathology or the disease process is directly related to problems within the cardiovascular space. Either it's the heart itself or the vascular space. And what is the vascular space? And I'll be referring it to vascular space a lot. So what is the vascular space? The vascular space is the network that allows blood to be moved throughout the body. The vascular space includes all of the blood vessels in the body. They can be arteries, arterioles, veins, venules, capillaries. And does the vascular space includes the heart? Yes, it does. So the heart is continuous with the vascular space and is a big partner in circulation. And the heart serves as the pump to support circulation, keeping the blood in the vascular space moving forward. Let's go to the next slide. How you'll treat a patient with shock depends on how fast you'll find the underlying cause, and how fast you'll find the underlying cause will depend on if you know what type of shock it is. And as a new grad RN, when you'll get hired, uh, the your training team will make sure that they teach you in the about this topic during this orientation, so you can be better nurse in assessing those early signs, so the shock doesn't go to the last stage and there is less chance of saving the patient. To define, shock is a widespread abnormal cellular metabolism that occurs when oxygenation and tissue perfusion needs are not met to the level necessary to maintain cell functions. Our body survives on our body cells, and the body cells survive on the oxygenation, and all these cells with proper adequate oxygenation perfuse lead also participate in the tissue perfusion all over the body. So any problem which impairs oxygen delivery to cells or further to tissues and organs can start the syndrome of shock and can lead to a very life-threatening emergency. And as I said earlier, all pathology is clearly related to cardiovascular space, either heart or the vascular space. Shock is classified as either circulatory or cardiogenic. Yes, in your book there are different kinds, but of those different kinds, there are two categories which are major. So, shock is classified as either circulatory or cardiogenic. Now, circulatory shock happens when the vascular space becomes empty. There is no volume. Volume is depleted, or it's too large, or the vessels are vasodilated for the available volume or obstructed. With cardiogenic shock, the heart ceases to effectively pump blood forward. With both forms of shock, circulation through the vascular network is impaired, and the cardiac output is going down, and the body's compensatory mechanisms immediately tries to restore the circulation. So as I said, shock is classified as either circulatory or cardiogenic. Circulatory shock occurs when the vascular space becomes empty, or it's too large for the available volume, or it's obstructed. With cardiogenic shock, the heart ceases or it stops to effectively pump blood forward. With both forms of shock, there is a problem with circulation within the vascular network, and the cardiac output is going down, and the body's compensatory mechanisms are immediately trying to restore this circulation. The most common cause of cardiogenic shock is sudden acute pump failure following MI, myocardial infarction. Now, circulatory shock, which is non-pump problem, is related to changes in the vascular space. Um, Now, hypovolemic. Uh, now, so shock is classified as either circulatory or cardiogenic. Now, circulatory shock has three types of circulatory shock, which is hypovolemic, obstructive, and distributive. And as you see the names hypovolemic, obstructive, and distributive, the name itself will give you some idea about what kind of shock is happening. So let's go to the next slide, and this is about hypovolemic causes. And the hypovolemic causes, the immediately it's about volume, so there can be loss of blood, or there is loss of fluid, which is or there is loss of just volume. So when there is hemorrhagic or loss of blood from the vascular space, the reasons can be many. They can be like a big trauma has happened, or some aortic aneurysm is happening, or during the the surgery, some complications happened related to some incisions, or some cutting of some arteries, or there can be some obstetric causes or OB causes related to the placenta or the fundus of the uterus, or there can be other OB causes like placenta previa, postpartum uterine atony. And when faced with obstructive problems, and if the hemorrhagic or loss of blood from the vascular space is happening because of OB problems, you think about bleeding first. And I know you all have gone through your maternal rotation, maternal class in your earlier semesters. The second cause is this intravascular dehydration due to loss of fluid from the vascular space. And the loss of fluid from the vascular space because of dehydration can happen because of many reasons. The common ones can be polyuria, diarrhea, or there is uh, di- um Addisonian crisis, diabetes insipidus, or when there is a procedure of paracentesis or thoracentesis and they are removing the fluid accumulation, then maybe at that time this intravascular dehydration can happen. But with all these conditions, the client or the patient is losing volume. And by losing volume for long enough from anywhere in the body, fluid volume deficit will eventually occur. The faster the loss of volume, the more life-threatening the situation can become. Now, the third reason, which is this intravascular volume loss due to massive fluid shifts and third spacing of fluid. Now, massive fluid shift. The first thing which comes to my mind is burns. When somebody has burns, like a very massive burns. Burns is like BURNS. B as in baby, U as in umbrella, R as in Robert, N as in Nancy, S as in sugar. So burns. When somebody has burns, there is an intravascular volume loss due to massive fluid shifts. That the fluid shifts. So it might happen. A very important life-saving fluid from the blood is leaking into the interstitial tissues, and it's of no use in this body circulation. So with these conditions, the volume may actually still be in the body, but it is not in the correct place, the vascular space. When the fluid is in the vascular space, then it is participating in the circulation. Since the fluid is not in the correct place, the body thinks it is in the state of shock and it starts compensating and the person is going down. Obstructive causes, as I say, something is obstructive, so blood cannot be ejected from the left ventricle into the systemic circulation because the position of the heart is displaced or it's compressed. Condition which can cause these are cardiac tamponade, any heart tumor, any mediastinal shift, any hernia, diaphragmatic hernia, or diaphragmatic rupture, or any pneumothorax. So these are the common conditions when the obstructive shock can happen. Distributive shock. Now, distributive shock is why it gets more attention because the most common cause of distributive shock is sepsis. Uh, so when there is a loss of um, vasomotor control resulting in arterial or venular dilatation and characterized after fluid resuscitation by increased cardiac output and decreased systemic vascular resistance, then it is known as distributive shock. In other words, um, you might not have low BP, but still your bodies are not perfusing adequately. So hypoperfusion can still happen in the absence of hypotension. So the blood volume is normal in the bodies, but it is not getting distributed adequately within the body tissues. So tissues are not getting adequately perfused. So this is why this is what happens in distributive shock, and most common cause of this is sepsis. So it has a definition. It is very medical. You that but the in a nutshell, it means that blood volume is normal in the body, but tissues are not getting adequately perfusing. They are not adequately perfusing. And conditions leading to distributive shock other than sepsis. So after sepsis is SIRS. SIRS is systemic inflammatory uh, response syndrome, and this is when the body is has a it is related to the response which is made by the body's immune system. And to explain SIRS, I need another video e-lecture. So for now, I just want you to know that the conditions which can lead to distributive shock other than sepsis is SIRS, toxic shock syndrome, anaphylaxis, any reaction to drugs, heavy metal poisoning, liver insufficiency, and then damage to central nervous system. So hypovolemic shock is actually a prototype of all shocks. It's kind of a model of all shocks. But with the exception of uh, distributive or vasodilated shock because of the common symptoms that characterize shock syndromes. Since the body cannot tell the difference among various clinical shock syndromes, only one set of mechanism is initiated in an attempt to restore or maintain the circulating volume regardless of the actual cause. So the common generic symptoms which are assigned to shock are actually pointing towards hypovolemic shock. But there is an exception of distributive shock. Now, in an attempt to restore or maintain circulating volume regardless of the actual cause, the body's compensatory mechanism by default starts during the shock, and then some generic symptoms are seen, and those generic symptoms are actually um, are seen in the hypovolemic shock. The compensatory mechanisms triggered by this shock syndromes, it really helps the person if he's in hypovolemic shock, because in hypovolemic shock, what the patient actually needs is more pressure and more volume. And it has to do with and hypovolemic shock, a definition is actually, so hypovolemic shock, as I was explaining, is to do with the volume of the blood circulating in body. And it's a prototype for all types of shock. Adequate circulating blood volume is important, and it's important for adequate cardiac output. And when the blood volume drops, the stroke volume drops, and so it further drops the cardiac output. And low cardiac output will drop the systolic blood pressure. Systolic blood pressure gives a clear picture of cardiac output. Now, low systolic blood pressure, when you have low systolic blood pressure, you think about vital organs, the vital organs of the body, what will happen to those vital organs. In hypovolemic shock, so I was on slide 10, now I'm going to slide 11. In hypovolemic shock, whenever body senses there is a lack of fluid volume, and there is a lack of volume of fluid or blood volume, it tries to compensate. And the body starts taking help from a volume of readily available blood and fluid that can be quickly shifted to the vascular space. And the hypovolemic shock, it results when you lose more than 20% of your body's liquid. It can be like blood or fluid supply. The severe fluid loss makes it impossible for the heart to pump, and then many organs start to fail. Body has a and when many organs start to fail, that means body has a failed attempt to compensate and restore the circulation. There are some things which is important in hypovolemic shock is that the whole blood in the body can be lost from circulation if there has been an hemorrhage. And the liquid portion of the blood, which is plasma, can be lost or from circulation completely due to seepage out of the vascular space. So it can there is something called capillary leak syndrome. So any injury to vessel walls, such as in a burn injury, can increase capillary permeability, means vessels are leaking, and it can cause a fluid shift out of the vascular space. And the vascular fluid deficit from extracellular fluid losses can also lead to hypovolemic shock. So in if there is a vascular fluid deficit from vomiting, diarrhea, or polyuria, it can also lead to hypovolemic shock. And the symptoms of shock occur because there is a rapid loss of circulating fluid volume. And it is not just fluid volume, it's the total body fluid. Uh, it's a total total fluid volume in a certain span of a time. A person can have a fluid volume that is not in the vascular space and therefore is not available for circulation of oxygen and nutrients to the tissues. Think about when the gas tank in your car is empty, your vehicle or whatever it is, your car cannot run. So when the vascular space is empty, the vital organs of the body can no longer perform essential functions for sustaining life. So this is what is happening in the hypovolemic shock. The causes of hypovolemic shock, it's dehydration, hemorrhage, intestinal obstruction, burns, and peritonitis. I put burns and peritonitis by mistake on the same bullet point, but burns and peritonitis is separate, and then ascites. Dehydration, when does it happen? It happens when there is excessive perspiration, diarrhea, vomiting, inadequate fluid intake, which happens a lot in older patients, and then if there is some kind of adrenal insufficiency. Hemorrhage, it is usually bleeding is usually due to trauma, massive trauma, or loss of whole blood directly from the vascular space. Um, Intestinal obstruction, it is excessive fluid shift when the materials in your bowel cannot move past the obstruction. So intestinal obstruction happens when there is excessive fluid shift, when the materials in your intestine, they cannot move past a certain obstruction. Burns, yes, as I explained earlier, burns is internal fluid shift. So the injury to the vessel wall increases capillary leakage, causing a fluid to shift out of the vascular space to maybe the interstitial body tissues. Peritonitis is inflammation or injury to vessel walls of peritoneum, and which can cause bleeding and again the fluid shift out of the vascular space. Ascites is excessive fluid shift between the membranes lining your abdomen and abdominal organs. Fluid leaves vascular space and it leaks into your abdomen. So that's what is ascites. An early signs of now in the following three slides, beginning from this slide, it's important. I have for this topic, hypovolemic shock. You will see how there is early, advanced, and late signs of hypovolemic shock, and how if a nurse knows to assess on time, she can save patient's life. So, and sometimes, you know, we try hard, but things, the treatment doesn't help, and we still lose the patient. So, early signs and symptoms of hypovolemic shock are restlessness, tachypnea. Uh, I think I wrote tachypnea twice, so please ignore it. Restlessness, tachypnea, tachycardia, apprehension, irritability, bounding pulse, thirst, and then reduced urine output and narrowed pulse pressure. Now, restlessness, when there is hypovolemic shock, sympathetic nervous system gets activated. It causes the release of catecholamines, which are uh, our stress hormones for fight or flight, commonly known as epinephrine and norepinephrine, and this makes the patient restless. And tachypnea, now there are beta receptors inside your body who respond to any cellular hypoxia, and so to and this will lead to bronchodilation, and when it leads to bronchodilation, the body will try to get more air in, so that's why it will have tachypnea. um, Apprehension irritability, because there is a decrease in cardiac output, and a decrease in cardiac output is leading to cerebral hypoxia, and the patient feels a sense of impending doom, that something is wrong. So that's why apprehension irritability is because of the cerebral hypoxia due to decrease in cardiac output. The bounding pulse is happening because the heart is pumping harder to get what blood is left out to the vital organs. Thirst is a very basic compensatory mechanism for any condition of hemoconcentration to replace fluid volume. And so thirst is a very basic compensatory mechanism when body wants to replace the fluid volume and there is a hemoconcentration. Reduced urinary output, kidneys, they will sense the low circulating volume and they will begin to reabsorb water, and they will decrease the amount of urine being excreted to offset the existing hypovolemia. So you will have reduced urine output. Now kidney says, I want my share, so I'm not letting it go out. So it will keep whatever the circulating blood, the volume is there. Tachycardia is another way of body compensating to maintain their circulation, and there will be a narrow pulse pressure. Okay, let's go to the next slide. Advanced signs and symptoms of hypovolemic shock. So weak and thready pulse, cool clammy skin, oliguria. Now, as blood pressure drops in shock, renal perfusion decreases, therefore reducing the kidney functions of filtration and excretion, and that's why the patient has oliguria. Hemoconcentration elevated hemoglobin. Now, progressive, like a gradual fluid volume loss through intravascular dehydration leaves a concentration of lot of solids within the vascular space, which in turn causes a very sluggish blood flow and can lead to tissue damage, and which may trigger another potential lethal complication of disseminated intravascular coagulation, or popularly known as DIC. So hemoconcentration is that when when the fluid volume is going out of those intravascular spaces, it's leaving a concentration of some solid particles within the vascular space, and which in turn will cause the sluggish blood flow, and it can lead to tissue damage. There is more concentration of particles in the vascular space, and with this there can be eventually a tissue damage, and it can be also a complication of DIC. Whenever there is a hypotension in hypovolemic shock, it says it's a hallmark of body's failed effort to compensate. So it's a hallmark of failed compensatory mechanism, and this will be reflected in a decreased systolic blood pressure. The cause of the shock has not been corrected. The backup system can no longer hold the cardiac output steady, and the cardiac output decreases as as reflected by the progressive decline in the systolic blood pressure. Now let's go to the next slide. Late signs of hypovolemic shock are decreasing LOC, apathy, confusion, coma, and this is happening because the cardiac output is falling below a critical level. The brain is no longer receiving adequate blood flow. Brain cells that require high levels of oxygen and glucose cannot continue normal functions of orientation, comprehension, responsiveness, and wakefulness or alertness. Shallow respirations, they are happening because with progressive brain dysfunction due to critically insufficient perfusion of oxygen, a structure called medulla oblongata of the brain, which normally regulates your respirations, it stops to relay the life-saving message for the lungs to take in more oxygen. So that's why they have shallow respirations. Late signs of hypovolemic shock is also oliguria or anuria. Kidneys are no longer functioning. Kidneys shut down secondary to continued loss of circulating volume. Then there is cardiac failure or circulatory collapse. And this is end stage. And this is when the anaerobic metabolism is happening. There is metabolism inside the body without oxygen. This is leading to more acidosis, which is depressing the heart muscle, and there is a circulatory collapse eventually. Hypovolemic shock, the usual ones, we will you will look at those, and you'll have low hemoglobin, hematocrit, RBC, platelets, potassium, sodium, creatinine, and BUN will be elevated, and urine specific gravity and osmolality will be high, pH will be decreased, and the blood test will be positive. Occult blood test will be positive. X-rays, so we can identify the bleeding sites. Again, gastroscopy to identify internal bleeding sites, and hemodynamic monitoring, and it will show that the venous pressure is low or the right atrial pressure is low, and there is something called pulmonary artery wedge pressure that will be low, and the most important, the cardiac output will be low. CT scan will help detect again any internal bleeding, and abdominal lavage will help detect abdominal or peritoneal bleeding. So these are some of the tests which we can do for hypovolemic shock. Treat the underlying cause is the most important one. Patent airway, oxygen, and I have used this term called military anti-shock trousers or pneumatic anti-shock garment. These are just the pneumatic anti-shock garment. It's an inflatable garment which is used to combat shock or stabilize fractures, promote homeostasis, and increase the peripheral vascular resistance within the body. And these pneumatic anti-shock garments, they are also known as mask suit. So these garment is applying continuous pressure over large areas of healing skin after burns, trauma, and surgical intervention, and they might be worn continuously for several months to a year. And it limits hypertrophy and contraction of scar tissue. So some anti-shock garments can be also used. Isotonic IV fluids, yes, isotonic fluid which mimics the body fluid closely, so they can be given as a bolus, and fluids to restore filling pressure, and then packed RBC red blood cells can be infused. And when the packed red blood cells infusion happens, remember to monitor for the initial reaction. Okay, now the plasma volume expanders and emergency transfusions may be indicated if the client's condition does not allow time for full time and cross-match procedures. So if there is a problem with the blood transfusion, then other ways of expanding the fluid volume in the body can be used, and crystalloids, colloids, electrolyte solutions are used for fluid loss secondary to burn wounds. If there has been an Addisonian crisis or diabetes insipidus, then hormone replacement therapy might be used. The complications deadly for these patients are dysrhythmias, arrest, organ failure, ARDS, DIC, and renal failure. Now we are coming to circulatory shock. To understand the circulatory shock, um, let's review the heart's structure. The heart is placed anatomically in the center of the thorax and between the lungs in the mediastinum. The heart is nestled in this very cozy space and movable. The heart is movable. It can be moved because it is hanging by the great vessels and surrounded and supported by the right and left lungs on either side and protected by a very good rigid bony rib cage. The diagram, the sorry, not diagram, the diaphragm closes off the thoracic cavity, which houses only the heart and lungs, keeping them separated from the abdominal cavity where all of the abdominal organs live. Now, because the organs in the thoracic cavity fully occupy the available space, any changes in the size or position of the organs within a thoracic cavity result in a full house within that cavity, and there will be a decreased space for normal function. The chambers of the heart as well as the lung tissue experience rhythmic changes in size and position as they perform their respective functions. So the chambers of the heart, they relax in diastole and they contract in systole to eject the blood forward. The lungs expand upon inspiration and then they deflate with expiration. And the available space in the thorax accommodates all these changes, size and pressure, allowing both vital organs in the thorax and the abdomen area to do their function effectively. Now, when there is an obstructive circulatory shock, it everything changes. It causes the organs to raise the roof and rock the house. So the house is all rocked. Everything is disheveled, like like mm, uh, changing. Everything is changing because there is some change in the space. So this in the obstructive circulatory shock, it results in squeezing or displacement of the heart from the center of the mediastinum, causing decreased ventricular filling and thereby decreased ejection capacity and a drop in cardiac output. So it has something to do with the displacement of the heart. Um, and some mechanical factors can be blamed for the interference of this filling or emptying of the heart or great vessels. That leads to the systolic hypotension and poor perfusion. Causes can be pulmonary emboli, which interferes with the ventricular emptying of blood, tension pneumothorax, cardiac tamponade, and atrial tumor or clot because of all these pneumothorax, tamponade, tumor, clot, there's not enough room in the thorax for the heart and lungs plus any abdominal organs. The heart is compressed by the extra pressure and ventricular filling is compromised. And this leads to decreased stroke volume and cardiac output, and there is obstructive circulation. Um, there can be diaphragmatic hernia, cardiac tamponade, cardiac tumor, or mediastinal shift. Heart is displaced or compressed here. Blood cannot physically get out of the heart to the rest of the body. So that's what is happening here. So this is slide 24 now. Signs and symptoms of obstructive circulatory shock. So let's begin from bottom. CVP. So because the heart is being squeezed, the pressure inside of the heart is elevated, is high, and all the chambers of the heart will reflect increased pressure. So that's why there is some um, um, high pressure, high central venous pressure. Muffled heart sounds. Why there is muffled heart sounds? Heart sounds are muffled when you auscultate through a when you put your stethoscope on the heart muscle over the skin tissue, because volume there is a because there is a heart sounds are muffled when they're auscultated through a mass in the cardiac muscle or volume of blood, or there can be some kind of exudates in the pericardial sac. So you can hear those muffled heart sounds. Um, Pulses, paradoxes, when the heart is being squeezed, when the heart is being squeezed or compressed, the cardiac output fails. So we are discussing about pulses, paradoxes, when the heart is being squeezed. The cardiac output falls. With inspiration, the lungs inflate and they draw blood right into the heart, pushing the intraventricular septum to the left and thereby causing increasing compression to the already compressed left chamber and the cardiac output falling further. So with each inspiration, the systolic pressure falls at least 10 millimeters of mercury, and with each expiration, it rises 10 millimeters of mercury. Um, so this is what happens in pulses paradoxes. So when the heart is being squeezed or compressed, the cardiac output falls. With inspiration, the lungs inflate and right they draw blood into the right heart, pushing the intraventricular septum to the left and increasing compression to the already compressed left chamber, and the cardiac output falls further. Think of this as a double squeeze. So this is what is happening in the pulsus paradoxus. Lung displaced trachea, lung collapse due to air or blood in the pleural space on the affected side. And this causes one side ventilation and a shift in the position of the structures. So that's why there is a displaced trachea or maybe displaced esophagus. Um, Systolic hypotension with decreased left ventricular stroke volume output. Yes, because this is the one of the signs and symptoms of systolic hypotension with decreased left ventricular stroke volume output. In the PowerPoint which I posted, I think I wrote systolic hypertension with decreased left ventricular stroke volume output. So I won't be testing you on this because I wrote hypertension. Actually, it was hypotension. So I corrected here. Distended neck veins. Increased pulmonary pressure causes backward pressure in the right heart. Elevated right heart pressure and elevated CVP cause the backflow that engorges the jugular veins. Then we have dyspnea, tachypnea. Remember that why shortness of breath is happening. Remember that circulating volume is normal in this form of circulatory shock. When blood flow through the lungs is compromised by a pulmonary embolus, air can't get into the lung for diffusion of oxygen into the blood. So the patient is having dyspnea or tachypnea. Let's go to the next slide. Test chest X-ray, echocardiography. Treatment, it's quite self-explanatory. I don't need to explain it to you much on this diagram. Much on this, sorry, in the slide. Distributive. Now there is a kind of circulatory shock which is called distributive. And what is the distributive presentation? The size of the vascular system is directly related to to the vasomotor tone. And what is vasomotor tone? Vasomotor tone is vasoconstriction or vasodilation, and this is under autonomic nervous system control. So the size of the vascular system is directly related to vasomotor tone, which is under autonomic nervous system control. And vasomotor tone is actually vasoconstriction or vasodilation. Now, vasodilation, it increases the size of the vascular system. If circulating volumes remains the same, the effect will be lower blood pressure. So when there is a vasodilation happening, it increases the size of the vascular system, and if the circulating blood volume within that vascular space is same, the effect will be low blood pressure. When there is vasoconstriction, it decreases the size of the vascular system, and if blood volume remains unchanged, because of the vasoconstriction, there will be a high systolic blood pressure. So this is the normal, this is the some important things which you should remember. So about the vasomotor tone and the relationship with the blood pressure. So distributive shock occurs when blood volume is normally displaced in the vasculature. For example, when blood is getting pooled in the peripheral blood vessels. And this displacement of blood volume causes a hypovolemia because not enough blood is returning to the heart and resulting in decreased tissue perfusion. So it is when the blood volume is normally displaced in the vasculature. And as I said, the principle to understand this or thinking behind this is to do with the size of the vascular system, which is directly related to the vasomotor tone and which is under autonomic nervous system control. So there are severe causes of distributive shock will be severe allergic reactions to insect sting foods such as nuts and shellfish, plants, medications such as penicillin in contact with latex and which causes anaphylaxis, and most frequent cause of distributive presentation can be gram-negative bacteremia. Also, there can be spinal cord injury or dissection of the spinal cord can also lead to distributive shock. When there is allergic reactions, you all are familiar, there is a substance called histamine and it gets released into the blood, which causes all the blood vessels to dilate all over the body, and this will induce the anaphylactic shock. The presence of because we have some systemic inflammatory mediators in the bodies which are becoming active due to body getting infected by any gram-negative bacteria, the body will release some endotoxins which will produce some generalized vasodilation, and that can trigger septic shock. So right now you're not learning about septic shock, but distributive shock can trigger septic shock because of some immune system response happening due to the bacteria invasion in the body. And so let's go to the next slide. Distributive shock sign and symptoms. The first thing to look is skin. So look at the skin color and temperature. It will be if patient has been having septic shock due to distributive shock, there will be a warm pink flush skin. If there is warm sensation, itching, burning, hives, or angioedema, and it's happening because of the histamine released by the body, and that's why there is an allergic manifestation such as hives, etc. They can be normal skin color also, but it'll be dry to touch. And there'll be systolic hypotension, but normal pulse. There'll be dyspnea, air hunger, wheezing, chest tightness, and coughing. Um, in distributive shock, the blood volume is normal, but because of vasodilation, the vascular space has become too large for the normal circulating volume of blood, and peripheral pooling of blood causes a sudden drop in the BP. Anaphylactic shock is a type of distributive shock that involves the immune system. And you can go through this definition. And the body has a great system for protecting itself against foreign substances, and that get past our gatekeepers. And we have some physical and chemical barriers in our body. So when foreign substances get passed through our gatekeepers, which then and they enter the body, um, then shock, this kind of anaphylactic shock can happen. And so it involves the immune system. Once inside if the foreign substance gets inside the body, the inflammatory response is activated, and then the immune system kicks in to defend the body against these invaders. And some immunoglobulins come and they play their role. So, this is what is happening in the anaphylactic shock. And this happens mostly to the people who are kind of little sensitive to a particular antigens, and the person through a period of time have become sensitized to this allergen after repeated exposures. And chemicals are released into the blood, they bind to your mast cells, and they start the cascade of complementary factors which lead to damage of vessels. They will increase capillary permeability and the leakage of the fluid from the vascular space, resulting in low volume and low blood pressure. Cardiac output will start failing, cardiac function will start deteriorating, and the lung function is compromised by bronchospasm and laryngeal edema. And this happens all in anaphylactic shock, and there should be something triggering this. So let's move to the next slide. And the something which will cause this, a trigger will be exposure to those sensitive agents, chemicals, food, drugs, hormones, insect venom, horse serums, vaccinations, allergen extracts, and food which contain sulfide. Um, Food additives containing sulfide. And you all are very familiar with the word anaphylactic shock. And that's why when we give somebody uh, some teaching about vaccinations, some of them they also have this content about anaphylactic shock. Next, sign and symptoms. So this was the causes of anaphylactic shock, and now slide 32 is sign and symptoms. There is a sudden nasal congestion because the fluid is leaking into the extracellular tissues. Blood vessels are dilating and they are bringing increased flow to the surface of the body. So there is flushed, moist skin. Feeling of doom will be there, anxiety will be there, and um, low BP will be there because the fluid is shifting from the vascular space into the tissue, and it is leading to the low fluid, a low volume in the vascular space, and so low BP. There can be uh, generalized edema because I said earlier there's leakage of fluid into extracellular tissues due to increased capillary permeability. Bronchospasms and laryngeal edema will obstruct the intake of oxygen on inspiration and oxygen, um, and that's why the patient can also show signs of tachypnea and crowing kind of sound. Uh, there can be red itchy veals You can Google what is wheals, and you can see what kind of uh, skin condition happens when the patient has wheals. Um, and it's a reaction to allergens. So they have wheals, it's just a reaction to allergens. Test the basics, determine the underlying cause, a skin testing, so we can develop what that specific antigen is making it happen. Treatment, the most important is maintaining a patent airway oxygenation, CPR, oxygen, intubation. Epinephrine is very important. So they are epinephrine is actually is a sterile aqueous solution, and they come into two ratios. One is to 10,000 and one is to 1,000. And each ml of 1 is to 10,000 solution contains 0.1 milligram of epinephrine and 1 milligram of sodium bisulfite, and the epinephrine ratio, which is 1 is to 1,000, it contains 1 milligram epinephrine and 2.5 milligram of sodium bisulfite per ml. And sodium bisulfite is an antioxidant. So when somebody has this anaphylactic shock, then epinephrine can be given IM or sub-Q, and we can use the 1 is to 1,000 ratio epinephrine and if the patient is conscious, and we can use the IV epinephrine if reaction is severe, and we want to reverse the bronchoconstriction and vasoconstriction. So patient is having problem breathing, we want to correct it, so epi will be handy. Okay. Treatment, steroids, so inflammation can be done, Benadryl to reduce allergic response, vasopressors to support BP, norepinephrine, which is Levophed to restore BP and to increase volume, some volume expanding fluids will be given, dobutamine to support BP, Trafalin to dilate the bronchi and reverse bronchospasms. What can harm your patient? The cardiopulmonary arrest, the circulation threat, the body, and immediate threat of death. So the most important anaphylactic shock is restoring the airway, maintaining the patent airway. Septic shock. Now, septic shock is caused by widespread infection, is the most common type of circulatory shock. And the very young and the very old both are at greater risk for septic shock. It is caused by any pathogenic organism. So sepsis, septic shock, or the sepsis is being caused by any pathogenic organism. And there is something in a body called cytokines. Their cytokines are substances which are made by immune system to fight infection. And cytokines and toxins produced by bacteria cause blood vessels to dilate, and this will decrease the blood pressure. Blood flow to the kidneys and brain will be decreased. The heart will start working harder to fight the decreased blood flow, only to weaken it. The walls of the blood vessels leak, and they allow fluid from the bloodstream going into the tissues, and this causes swelling. And this can immediately develop in the lungs, and it can cause respiratory distress. Respiratory distress. So clients with weak immune system, they allow bacteria to take control of their immune system. So the weak immune system will be kind of helpful for the sepsis causing organism, microorganism. Also somebody who's going for chemotherapy can also have this kind of shock. Now bacteria can easily find its way through the body due to the opening which the man can create, like invasive tests, treatment, surgeries, or trauma happening, and this can create some opening in the body, and bacteria can harbor there, or bacteria can harbor on any prosthesis if the patient has is a example, if somebody has a prosthetic hip, then bacteria can harbor there for a while and can lead to septic shock. So that's one of the reasons. Let's go to the next slide. Sign and symptoms: alteration in temperature, warm flushed skin, low BP, confusion, hypoventilation in early shock, and low ventilation in late shock. Test blood cultures because we want to know what the organism is. CBC, we want to know what blood components are, and the liver panel to elevate, see the bun and creatinine, what is happening, and then prothrombin time. I think liver panel is a renal panel. Sorry, I wrote liver, it's renal panel. And then prothrombin time and partial thromboplastin time will be abnormal. Like, we want to we want to know the bleeding time in the body too. Um, Septic shock tests will be also urine studies, which will measure the patient's specific gravity, arterial blood gas to know any acidosis or alkalosis happening, and also again hemodynamic monitoring to know about the any pressure in the heart chambers. Antibiotic will be the first thing. We will give some broad spectrum antibiotics to this patient, and and as soon as the blood is drawn, the broad spectrum antibiotics are given, and they are continued for 48 hours until culture reports are finals. Some drugs, dopamine, dobutamine, norepinephrine, they will all be given because they will improve the tissue perfusion and will maintain the BP. And also the goal is to maintain airway, and if it's required, prepare for intubation and ventilation. Preventing or managing respiratory distress is important. Oxygen, increasing oxygen will help in the septic shock. IV fluids will help to maintain the intravascular volume. So some other some other antibodies will be given to counter the septic shock mediators in the body, which are going to compromise the circulation. Cardiogenic shock, it's called pump failure. It's a condition of diminished cardiac output that severely impairs tissue perfusion. Cardiogenic shock can happen because of a damaged muscle, poor ventricular filling, or poor outflow from the heart. I would be, let's go. Yeah. I would be only interested in testing you on cardiogenic shock if I have to test on the causes or sign and symptoms. So as it says cardio, so it has to do something with the cardiac problems. So the cardiogenic shock cause is myocardial infarction, any ventricular arrhythmias, which are like dangerous, end-stage congestive heart failure, cardiac tamponade, and mediastinal shift. Mediastinal shift happens as pressure builds up in the pericardial sac and it displaces the heart. For example, when a patient pulls a knife out of his right chest wall, the sucking chest wound collapses the right lung and the pressure displaces the heart to the left. The heart can't pump very well from under the left armpit. So this is what is in the line of understanding how the mediastinal shift is happening. Sign and symptoms: tachycardia, hypotension, cool, ashen skin, diaphoresis, cyanosis of lips and nail beds, and then test enzymes, ABGs, cardiac cath, EKG, again hemodynamic monitoring. Treatment, again patent airway, a lot of oxygen, fluids, and vasopressors to reduce the left ventricle workload. We can also do some procedure called intra-aortic balloon pump therapy, which will reduce the left ventricle workload by decreasing the systemic vascular resistance. We can go for revascularization, which will restore the coronary artery blood flow if the cardiogenic shock was due to heart attack. Emergency surgery can be done to correct the problem within the heart structures. Ventricular assist device, which assists pumping action of heart, uh, can be implemented when intra-aortic balloon pump and other drug therapy has not been successful. So here it is, we come to the end of this slide on shock. So hypovolemic shock is something which can be uh, highlight of the test. Okay, thank you.